Primary hyperoxaluria, or PH, is a collection of rare genetic diseases where the metabolic end product, oxalate, is overproduced by the liver. It first targets the kidney, where hyperoxaluria leads to calcium oxalate crystals, therefore kidney stones and nephrocalcinosis. And later, when kidney function declines, it also targets other organs. pH subtypes are categorized according to specific genetic mutation, leading to different enzyme defects of the glyoxylate metabolism in the liver. Its genomic prevalence is much higher than the current prevalence data worldwide. pH1 occurs with a mutation in the AGXT gene, altering the function of peroxisomal alanine glyoxylate aminotransferase. It's the most common type of the disease, affecting up to 80% of patients. pH2 occurs with a mutation in the GRHPR gene, altering the function of glyoxylate reductase hydroxypyruvate reductase. pH3 occurs with a mutation in the HOGA1 gene, which alters the function of the mitochondrial enzyme 4-hydroxy-2-oxoglutarate aldolase. pH2 and 3 each affect approximately 10% of PH patients. Symptom onset of PH can occur at any point in someone's life. Infants that develop the condition fail to thrive and develop either stones in the kidneys or kidney calcifications, called nephrocalcinosis. They frequently develop infantile oxalosis, which is defined as early end-stage kidney failure and severe systemic oxalate deposition. When children, adolescents, and adults experience recurrent kidney stones, the underlying disease must be diagnosed as early as possible. However, many adults are not correctly diagnosed until the disease has caused kidney damage or kidney failure. In these late-stage patients, crystallized calcium oxalate isn't just prevalent in the kidneys, but has usually spread to other parts of the body like the bones, skin, retinas, and myocardium. This systemic oxalosis leads to a milieu of other symptoms, depending on the organ affected, such as osteopathy, retinopathy, and cardiomyopathy. PH diagnosis is done through consideration of clinical symptoms and special diagnostic tests. After the first kidney stone in children, and in all adult patients presenting with recurrent calcium oxalate stones, or definitively those with oxalosis, pH screening must take place. Tests include urine analysis for oxalate and glycolate, indications of pH1, glyceric acid for pH2, or 4-hydroxyglutamate, as well as 4-hydroxyoxo and 2,4-dihydroxyoxoglutarate, indicators of pH3. If plasma is analyzed, oxalate and glycolate are measured. Rarely, glyceric acid is elevated. Ultrasound or CT is used to identify kidney stones, while oxalate deposits are identified in the bones using MRI. In the heart, through speckle echocardiography, or the retina by slit lamp examination or indirect ophthalmoscopy. It is imperative that family screening takes place if one person is diagnosed with PH. The standard of care treatment for all PH forms includes hyperhydration and alkaline citrate medication. In some PH1 patients with specific mutations, treatment with vitamin B6, the cofactor of the defective enzyme AGT, can normalize oxalate production and thus urinary excretion. Emerging therapies such as RNA interference or RNAi should be considered in those PH1 patients unresponsive to vitamin B6. The RNAi drug lumasiran can be prescribed to block the endogenous oxalate production by inhibiting the liver-specific enzyme glycolate oxidase, upstream the metabolic defect. In patients with kidney failure and dialysis, transplantation must be planned early, as no form of dialysis adequately removes oxalate. The only currently available cure for PH1 is liver or combined liver-kidney transplantation. In B6-sensitive PH1 patients, or those treated with RNAi, and in more or less all PH2 and 3 patients, only kidney transplantation is considered. Early diagnosis can prevent morbidity and mortality, and the new RNAi treatment option may prevent the necessity for transplantation in the long run. For more information, visit www.phhp-team.net.